Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa, and today I am joined by Dr. Carl Paige. Welcome.
Well, thank you very much for having me on.
So I am so thankful to get to see somebody from my local area, but we're going to be having a conversation that's more national or even global in scope. And I'm so thankful to get to live nearby someone who is making a big impact. So thank you for making the time to talk to me today.
You're welcome again. I'm happy to be here.
So
It's not my nap time yet, so
we're recording this at night, so we're staying up late to do this, right? So I would love for you to share your background as a primary care provider and kind of like how you came to practice in a transformational way now.
Sure. Well, I went to medical school in the early, I guess, fours when I went to medical school, and I didn't really know what I wanted to be. I performed really well in school, but I was attracted fairly quickly to some of the primary care. So I went into internal medicine and pediatrics after I graduated, which was a pathway to primary care. I wanted to learn as much as I could about as many things as I could. There's a nice database about how to just assess everyone from once they were, birthed all the way to really old age. So that brought me into the primary care space, which at the time and still to this day is relatively underserved. Because of that, and I really was able to move right fairly quickly into practice and get busy, So I went and I didn't do like a lot of my colleagues at the time were doing and go into a bit, join a large group or go work at a corporate entity. Back then, you could still get a shingle, and my wife had worked at the bank, and we figured out some demographics as to where the need was for primary care with some of the demographic data she was able to pull from her job at work, and moved to Oldham County in a suburb of Louisville, Kentucky, and it was just to hit the ground running. Essentially, I was very busy within 90 days. Just got busier and busier. And it was a privilege for a good 25 years or so to be one of the busiest people in that county and on the east end of Jefferson County, and grew a couple of large practices and sold them out there. But that really brought me the ability to see, hundreds of thousands of patient interactions. So it's just a large database of people in front of you. You can go and learn about it in the book and think you know what you're going to do, but you don't really know until you've seen a lot of normal things. Then you start to figure out what's not normal.
Yeah, exactly. And so you were seeing people from children all the way up through old age, right?
I started out being, it was the first full-time pediatrician in Oldham County, so I started seeing newborns and well checks and school physicals. But then, I was an internist too. So I trained in that as well and got boarded in both of those, internal medicine and pediatrics. So the parents figured out, hey, you can see me too. And then they're like, hey, can you see grandma or my aunt? And so in a small community like that, and it was a very good skill set to be able to become a busy practitioner quickly.
Yeah. My primary care provider sees everybody in my family as well. And so
Yeah.
I
And
really,
everybody liked that. And back then there was no HIPAA, so you could really talk to everybody about everybody else,
right. And then I think your wife likes to brag on you for being such a fixer. So were there a lot of conditions, like you said, would come up and they were kind of a mystery that you had to solve?
Well, I think really what I've been like that since I was a little kid. I used to like to take things apart, put them back together, and try to figure out what's wrong with them. Maybe if it was just mechanical things or that type of, just from a kid all the way as to, as an adolescent, fixing cars or whatever. I would mess around with stuff like that. Now I fix old tube amplifiers and guitars. So that's my hobby thing to do, sort of in a non-medical space. But being in a semi-rural location like we were there, there was the patients in the community we lived in, but there was also several counties between Louisville and Cincinnati that essentially were very underserved. So we saw most everything that was normal, and then we were sort of the first line of defense in the specialty space. Many people didn't want to go into the city to see a specialist, so we would have to see them and try to figure it out. It was enough for them just to come an hour into where we were to be seen. So it did allow me to see a lot of things that probably you wouldn't see if you just set up practice in the city, because the model there is to just refer out to the specialist everything. So I got to see and manage a lot of things because of the geography of it. And it really, and I like that. I wanted to be able to take care of everything from the, ground up.
What would be some examples of things that you would normally refer out that you managed?
There was early on, there was a lot of fertility stuff. This was really before infertility got big. We would see before it became a business, essentially like it is now, where it's all about procedural, IUI and IVFs and things, which, it's okay to do that, but there's a lot of things that you can do before you get to that space. So, just one of the early ones was a lady who had multiple miscarriages. And I think at this time, I literally just put her on baby aspirin. And when I first saw her, I'd only been practicing for 2-3 months, and she didn't come back. And I thought, well, I thought, this is, and then she came back like 10 months later and she had a baby. So I was like, she said it's because it's the first time she'd ever been able to get pregnant and carry it through the term, just because I put her on baby aspirin. So I was like, that's pretty cool.
Yeah, it's great to actually go through the process of elimination and check and see what will work in a low intervention way. And then what brought you out of that traditional setup into starting a more unique kind of practice?
Well, I was always interested in things that we had learned in the traditional model. And again, in internal medicine and pediatrics, it covered everything you could do without cutting somebody open. We injected joints and poked holes in your chest and stuff, but we didn't do surgery really, other than minor skin stuff. So, I got a large exposure to things like that. What I noticed was after a while that as I got busier in practice, you just basically were isolating these list of problems for patients. And then that was always then tied to here, they need this particular pharmaceutical intervention that the latest drug rep came in was going to tell you about. And then after 3 or 4 years of whatever that product was, they miraculously came out with one that was slightly different, that somehow was miraculously much more expensive and was going to be tremendously better, and really wasn't that much different than the first one. And everything seemed to fall in this just linear paradigm of like what most Western allopathic medicine is like you have one problem, one solution, and it's always a big pharma intervention. So just intellectually didn't seem right. And then there was always those patients that I would see that they had been to, the GI doctor and the cardiologist and the pulmonologist, and they had this list of complaints that just didn't quite fit into anything. And they were told or just said, well, maybe it's just mental. Let's put you on the new SSRIs we have out. I'll tell the patients that I would say, look, you may be crazy, you may need to give you this medicine, but that doesn't mean that's why you feel bad, right? That may not be the underlying problem. We're more like treating a symptom. So I'd started early on working on trying to figure out what was going on with some of these patients. We just did not have the training and the tools that we were given in traditional model to tell them how to address that. So my wife went through a bunch of things with her personal health after we had 8 kids. We had 6 of them in 7 years, and she ended up with a lot of GI issues from multiple antibiotics and C-sections. And so one day she kind of shook me by the head, and she'd been to all my friends, and they said she needed Prozac. And I looked at her and I said, look, you said you might need Prozac. You have always been a little crazy, but I don't think that's what's wrong with you right now. She's already had told me that. So I had to go and figure out about, leaky gut, intestinal permeability, and, food sensitivities and immune dysregulation, and, chronic persistent viral infections. And, there's a whole world out there that basically the non-patentable big pharma world didn't have an answer for. And we just were never exposed to any of that. So I've kind of found the best tools I could find to credential and learn in that space, and then started to integrate that into my primary care practice.
And then tell us about your primary care practice now at this point. It's called Medical Transformation Center.
Yes. Well, I had 2 large primary care practices in Oldham County and Eastern Jefferson County for 25 years. I sold both those. The last one I think was 2015 or 17. So officially do primary care anymore. When I started going into more of the integrative, the cellular medicine and regenerative space, that is more like a specialty. It's long appointments. You sit down and discuss and spend a lot of time poring over data. It's not really practical, and that's what we found when we tried to integrate the two together. It was you had to kind of do one or the other. Being a primary care doctor in 24/7, 365 days a year, I'd done that for 30 years and was probably a little tired too, from that. But to do that and then still have the energy to spend with these complicated patients that had a lot of thought process that needed to go into it was very difficult to do both. And the prevailing models of care and the insurance-based model did not value spending time with patients. So, you could do that and you would basically be having a very expensive hobby, but it was not going to be a business model that was going to be very successful either. So that sort of drove us into the, care model that we have now, which allows me to see those type of patients. But, we don't provide primary care anymore because it's just really impossible to meld the two. And it got to be difficult too when we were merging them I would have, some of the patients wanted to do the integrated care, go into detail and work on lifestyle and nutrition and use things we had in the regenerative space, like, peptides and stem cells, but most of the patients wanted to just give me my blood pressure, my diabetes pills, my hypertension pills, and I'll see you in 6 months, And so I was intellectually a little bit of a, I know there's a better thing for you to do, but it was hard for me to keep handing out these other things on the one hand while I knew there was a better option.
Did it cause some cognitive dissonance for you?
Yeah, absolutely. That's the right term for it, is cognitive dissonance. Yeah, it's it's to some point you just like, I want to do this. I don't want to do this anymore. Now I still use some of the tools we had in primary care. We manage a lot of people in cardiovascular risk modulation and things like that. And there's a lot of nice things I learned there. So I haven't abandoned that. And it's nice to have that database of things that I learned for all those years to pull on just from a disease state database that you've seen and so many things before. But the management tools we use are used differently. It's very much more proactive and it's more looking at things in that, not in that binary sense of you're either well or you're sick, but more like what's optimum health, how do we achieve that? Or if you're not well, wouldn't we like to identify that well before you actually were sick, not just like suddenly you're sick when your A1C is, 6.5, maybe it was not good that your A1C was 5, or 5.5, sorry. Yeah.
Well, and you do see people who would otherwise be qualified as sick. And I want to thank you again for helping one of my best friends who she's seen so many different doctors who refused to really engage with her and treat her because her situation was so complex. And like you said, she didn't fit in that box of, oh, this is definitely a respiratory problem with a respiratory answer or a GI problem with a GI answer. She has a systemic disorder that I really appreciate you taking the time to treat. And I have seen over the last, I think she's been seeing you almost 2 years now. When I first met her, she was almost disabled by the pain she was living with. And now it doesn't hurt her to go about her daily life. And she was already doing as much as she could with nutrition alone beforehand. I said, I've been a lot healthier because she cooks for us once a week. And so I'm healthier for it. But you were really able to fill in a lot of those gaps that other people literally would not see her for, because she's like, I want to be tested to find out if these are problems. And other people wouldn't even investigate.
I think that they don't know how. And then when people show up and they're complicated like that, it's always intimidating for doctors when we don't know what's going on, right? We're supposed to know everything. So I do think it's a little bit of a unfortunate position that traditional healthcare has put itself in. They're the experts in everything. But if you don't fall into one of the categories that they approve of, then something's wrong with the patient, and that's not really intellectually valid way to look at it. And that's the cognitive dissonance I had with it. So I had to go to learn a whole new set of ways to do things. So working now in the, looking at immune regulation, cellular mechanics of production of energy at a cellular mitochondrial level, how does your immune system modulate itself, not just turn the immune system on or off. working with peptides and small molecules and bioregulators and all these tools that we have now to work with that are available, things that, just aren't in a state where they could be patented and stuck in a really fancy box and marked up 10 billion% and sold at the pharmacy locally. That there's a lot of stuff out there, and some of it's just grassroots nutrition, figuring out that you've got permeability in your gut membrane, and then it's altering your immune response. That's the type of thing we deal with now. And we do see some very, very sick people. I don't want you to think we don't see sick people. Some of them are some of the sickest people out there, but, we do have time to spend with them. We don't go to I don't do hospitals and ERs and nursing homes and stuff anymore. It's just at some point I had to draw a line in the sand from a quality of life standpoint, to how much time I'm going to spend at work versus I've got to, make myself stay alert and be able to actually spend a lot of time now training other physicians. We'll spend about one weekend a month, going across the country in small groups, working with other physicians that are interested in working in this space and just doing a grand rounds concept with the educational group that I work with. And that's been a lot of fun. Pass the knowledge on.
So what's the name of that group if somebody wants to check it out?
It's called FSSRP.org, or Seed Scientific Research and Performance.
SSRP, not SSRI?
SSRP, yeah.
Okay. All right. And I think you describe kind of your approach as being functional medicine at this point, right?
We used functional early on. My initial training was sorry if I talked over you. I thought I didn't mean to. I thought you could talk. But my initial thing that I trained in when I left, or didn't leave, but when I trained outside of, my traditional internal medicine and pediatrics, was the FAARM, which is the American Academy of Anti-Aging and Regenerative Medicine. And I got a fellowship or a board certification in that, anti-aging and regenerative medicine, which they now sort of rebranded as nutritional and metabolic medicine. And then I did a fellowship in functional medicine. So functional medicine is really a concept of, finding that sweet spot of where things should be, as opposed to that binary, you're sick or well kind of concept. And also looks at root causes of disease, as opposed to just looking at the concept. There would be tree with roots as the, genetic or lifestyle or nutritional causes of the problem. Whereas the problem would be out at the leaves, and that's high blood pressure, diabetes, immune dysregulation. So it works more from the ground up. We don't use the labeling of functional medicine in the office a lot now because it kind of got watered down a bit. Pretty much anybody can do it never really did reach a level of credentialing and board certification in that area. So a lot of people now take a weekend seminar and they're functional medicine experts. So we kind of quit using it as a label because it just wasn't me, because you don't really know if you're using that as your credentialing, what does that actually carry with it? I'm glad these people are doing it, but it doesn't, there's so many levels of how to claim that, moniker.
Right. And that's something that I really respect about you, is that you're not in this for a trend, and you're not in this to say, oh, this is popular now, I'm going to learn how to do what is on trend and be this fancy concierge doctor. Like, you're really on a mission to help people get better, and you have this foundational knowledge and experience. And like you said, you went out and got additional board certifications. Like, you didn't just take a weekend conference. You've invested decades of your life expanding your,
I don't think I ever quit going to school, but but that's okay. I really, if I'm going to, traditional medicine, and this has, been borne out, most doctors get out of school, and after 3 or 4 years, they literally just do the same things over and over again until they retire, and they don't change their prescribing habits much. They unfortunately, and this is what really turned me off from the traditional, was that you would go to CMEs, but it was all given by the big pharma industry about whatever the latest thing was. So there was no learning there. It was just like indoctrination, and this is what you must prescribe. So I was very blunted from an intellectual standpoint with that. So the things I study now are really like, spend a lot of time looking at, research data and articles that are published either here nationally or internationally, and what are tools that are out there that have, reached safety data, got the ability to availability for the patients that have, spaces we can use them in. So there's a lot of repurposing of traditional medicines using those peptides and small molecules and bioregulators that are available and FDA cleared for use, but they haven't been given a specific use. Things like even the GLP-1s and the GIPs, that are so popular right now, they were out there for 20 years now. People just didn't use them very much. And they're peptides, and were available for use. And so we use all of that stuff. You just have to understand how it works. You can't just it's not like here's the diagnosis and then you look at the patient more like, it looks like you're not producing energy properly. Maybe we'll give you ketones, or it looks like you have, immune dysregulation and some gut permeability. Let's seal that gut in with something like liraglutide and then remove the food trigger and then use something like a thymosin alpha to regulate the immune response to help dampen autoimmunity. So I mean, it's a very multifaceted approach that looks at the whole patient, and that's not easy to do in a 7 to 8 minute office visit that you send a bill off to the insurance. That's why this, unfortunately, is not set up for that in that model.
Definitely. Well, and that brings us to the $1 billion question. So every time someone comes on the Nurse Rosa's Insights podcast, I ask, if you were given a grant for $1 billion, how would you like to see that used to meet the needs that you see and have the most sustainable impact?
Well, I sent you an answer on that. And after I thought about it a little more, the first thing that I thought of, just to preface what I'll say, is what we might work with, is that I think $1 billion is not enough. Okay. Because, if you just look at the cost to bring in one drug to market in traditional FDA, approval world, it's like $3 billion to bring one drug to, and then I looked at like marketing from top healthcare systems. It's like each of the top healthcare systems, they're spending $2 to $5 billion a year on marketing. Pharmaceutical companies, each of them spend the same amount, $5 to $10 billion a year. Medical device companies, all $10 billion a year. So you're trying to move the needle a little bit. There's just such a, every night you watch television, it's just Pfizer. I'm just picking on them, but it's one of the kids asked me one day, what's Pfizer? And it's like, why? Because every time I try to watch a football game, it's like this all the time there's Pfizer. And I'm like, you're battling trillions of dollars of propaganda in one space. So the $1 billion is like dropping the bucket in that space. But I do know it's an unfathomable amount of money, $1 billion. But when you look at the amount of resources spent in this space to shape public opinion, to really starting at childhood age on up, I think you should change it to Nurse Rosa's like $100 billion question.
Well, there's a reason for this, though, Dr. Paige. You don't know about this from the beginning, but this was inspired by Shauna Butler, who is a nurse economist, and she was sharing on her podcast about research that was done by the American Nurses Foundation about philanthropy that is directed towards healthcare, and what of that philanthropy involved nurses. And 1 penny of every dollar that is given towards healthcare philanthropy is directed towards nurses in some capacity.
Well, that's
So in
I
order,
get it. I'm not making fun of you.
no.
Yeah.
I want you to understand kind of where this is coming from, because there's a stewardship aspect as well, right? It sounds like a really big ask on the front end to you and me who don't write checks for $1 billion. But
Right.
also, it is not an impossible amount to ask a billionaire to write either.
No.
So
Yeah.
we just have to be good stewards of it. What if we were to double that amount and direct it towards nursing? Well, we would need to use it strategically so that it would have the most effective impact. So that's why I used 1 billion, because there's like
Oh, that's fine.
100
Thank you
billion.
for clarifying that. I wasn't trying to put down your number.
Oh, no.
It's just when I started looking at it, I was like, what are we competing against? That was the way I started looking at it. But, I think the type of things that the regulatory apparatus it's like most of government. We're in a time where we're getting a lot of political upheaval now with the change in administrations. And I've always been a big fan of like disruptive innovations, things that like come in and shake the walls up a little bit and make people have to look at everything they do and decide, is it really valid or not? Should we rethink how we approach even the problem from the ground up? You just layer and layer on different bureaucracies and rules and committees. And after a while, it's like, the patient's way over here and the people actually taking care of them are way over here. And there's just not connected anymore. And we've kind of got to that state in healthcare right now, and the way it's delivered, there's too many, barriers between that provider, whether it's physician or nurse practitioner, PA, and what the patient's needs are and what you're able to do for them. And a lot of that is driven by the bureaucracy of healthcare. So, it would be nice to sort of unfetter that a little bit. I do think you see some of that with the direct primary care model now, where people are stepping out of some of these big corporate entities. At the bigger level, having these, they used to be called DRGs, disease-related groups, where you have a patient come in the hospital and they all got treated the same way. And, that looks good to an accountant. I get it. It probably looks good to somebody crunching numbers, but it doesn't. Everybody's individual. And, the concept of personalized medicine and targeted precision medicine, now that we have access to, the genome all the way from the ground up, and the epigenome, and looking at, genomic expression testing. And, there's so many tools that are out there that, it's almost disincentivized to look at some of this high-tech stuff and the tools that we can use in the patient interaction now, because it's all supposed to be dumbed down to how quickly can you do it and how cheap can you do it. So I think that's just a broken model. That's why I left it. So I think more people should leave it and move out on their own and step away from that. But if you could, invest into, scenarios and networks where it would help people move into that space and get, $1 billion to get a lot of people practicing in that space. That's a lot of, capital to start up small businesses in that space, as opposed to the giant behemoth oligarchy sort of things. They're really multinational corporations now that run healthcare,
Exactly. And you got there. It's about having that sustainable impact, right? Making what looks like a really big investment into something that seems small, but then it can have a huge ripple effect. And so I think you hit the nail on the head that it's about investing in the people who are on a mission to have that impact. So maybe some billionaire's ex-wife will listen to these episodes and find their next donation project.
I hope so.
Maybe.
So. I appreciate the effort you're putting into making it happen.
Yeah, definitely. Well, you're doing great things in the world. I appreciate you. Thank you for coming on the Nurse Rosa's Insights podcast. If you've enjoyed this episode, to my listeners, please subscribe on whatever platform you're listening, or if you're watching on YouTube, and I'll be looking for a new guest to have on the next episode. So if you know somebody who has a great idea of how they can make healthcare better, they just don't have the seed money for it, point them in this direction and they can apply to Beyond. And I will see you in the next episode.
Thank you.